See if we get folks showing up, otherwise we
Yeah.
have to do the non-action. I'm thinking that a bunch of people, I know we're trying to.
Mm-hmm.
So that would be Ed and Darlene. Are you speaking at that? Mom. So we'll attend it last month. I'm getting these robocalls from somebody saying, our records indicate that you were a loved one, maybe suffering from chronic pain.
I got that same one yesterday. And I actually got that call 3 times because it was like the second or third time. It was the third time I figured out what it was. Because the first 2 times I to press 1 now, but except for I just couldn't hear the first because they went straight to voicemail. And then, or press 9 to unsubscribe from these calls. I was just like, really?
Now I got one that said I was convicted of 5 felonies and I needed to call right away.
Oh gosh.
For the IRS?
Yeah. So Megan DeVolt said she was getting her blood drawn at noon, so call in right after.
So Brian's on.
Brian. We're waiting to see if we can climb our way to a quorum, Brian, so.
Understood.
Need 4 more.
How many do we have on the phone?
One, just Brian. No, you can. Who are you counting?
Oh, I thought you said there were 5 here.
Or 1, 2, 3, 4. I just count 4 of us here.
Brian on the phone is 5. Megan said she's 6. Ed and Darlene. Ron and John. Ronnie's not going to be able to be here. She is out of town.
Hi, this is Darlene.
Hi, Darlene. Hey. Jalen's getting married. Yeah. Hey, Tanya.
You know, mine are cute. Yeah.
Tanya, you want to sit at the table? There's legs over there.
You have 6 on so far. 7 coming.
Stephanie, 5. Ronnie's out of town, I think, with moving. Caitlin's getting married. Caitlin's getting married? Caitlin's Stafford. And John. Give him 5 more minutes. Okay, you guys, hang in there. We're gonna give him 5 more minutes. We'll get started. I just got it. One more.
Is it in the bowl?
On the phone.
She's getting her blood drawn. It was in color.
Oh. Not this.
There was
Hey, here. Oh, good.
Yay.
Good.
Thank you.
That's just sweet. Oh. Here we go.
Maybe I can change the wording
One more.
as part of our cooperative partnership.
Yeah.
Because they're gonna want to yeah, exactly what we're doing. So is it a cooperative partnership with COA or is it a cooperative?
Hey.
Are we ready? Yeah. How do I word that? I'm gonna send you language.
Well, let us call the meeting to order. So welcome, everybody. So, would like to call the meeting to order.
Okay, yeah.
What's this morning on the longest day of the year? Feels like it already. After very vibrant thing this morning. So, I'd like to welcome everybody to the meeting. And the first thing that we're going to do, as we do at each meeting, is review the attestation of the conflict of interest and self-dealing transactions. So if you would just take a minute and look through that. And go to 2 paragraphs at the top. And if anyone sees through the list of the agenda items, anything that they see or perceive to have a conflict of, they would speak up. Appreciate that. Madam Chair, I would like to point out that one of the items of action in front of the board today do include dispersals to organizations that are represented on this board. So I don't know how you would like to handle that, but Catholic Family and Child Services, Comprehensive, Bonnie Baptist Community Services here today, and then Mon Valley Farm Workers, they are included in that distribution of behavioral health consent. So typically, when we get to those items, most people would just not vote if we're taking action on it.
So we'd like the quorum to pass those items.
Yep.
So we would probably not be able to take action on it. Well, that's not true.
But it's still not majority.
We still have quorum. We still have
majority, so we would have to extend.
I don't know how else you're gonna do it, because otherwise you'll probably never have, we still have, we still have four.
I would get on the phone with,
Practice the organization.
yeah. Okay, so, is anybody opposed to that idea? To that, and on other boards I've been on, it would still be a forum.
Yeah.
They just would have to abstain.
Yeah.
Because an abstention is still a vote.
Right.
Okay, so then let's go ahead and, start with the consent calendar. The board meeting minutes, so have folks had a chance to review the minutes from the last meeting? And, so as soon as someone who was in attendance at the last meeting,
I'll motion to approve.
Sandra, Lori,
I'll second.
discussion. Any other comments? So all in favor to approve the minutes?
Aye.
Aye.
Any opposed? Minutes are approved. Okay, so I think we're next on to the presentation from the silos, the transformation of care. And this is Sam. And Sam, you have a soft voice. I might ask that you get a little closer to the microphone.
We want to just move it over there? Or move that over there?
Yeah.
I meant speakerphone, right? So whatever works best.
So we briefly touched on this, actually in more detail, different aspects of during the practice transformation work group. So since we're sensitive on trying to explain today, we're going to go through very quickly right now. Right. So what's the difference between transformation of care, PCMH, patient-centered medical home, and change concept? The reason we're having this discussion is working with the different practices, transformation of care was excluded from those definitions, and they couldn't understand the correlation between those. So I wanted to make sure that we're all on the same page. Healthcare transformation. Healthcare transformation is an effort to reorient the entire delivery system around the user of the industry service the patient.
We have one.
Patient-centered medical home, also referred to as the primary care medical home, advanced primary care, the healthcare home. The PCMH is redesigned to approach to primary care. Again, it's an approach, technique, used as a strengthened long-term relationship between patient and primary care team as central to better care. And it's also applying those simple tools to make sure that we are doing the transformation. Patient-centered medical home, research identifies 6 fundamental elements that define a primary care practice as operating as a medical home. The care team that extends beyond the primary care physician, which also decreases burnout. It also increases satisfaction, disease registry utilization, comprehensive care delivery that involves necessary prevention and chronic disease management, active patient engagement, improved patient access, and cross-continuum care coordination. Probably all the different concepts we just talked about today. Could you go back to that slide? Do you have a definition for care team? So care team is the relationship between the internal practice. A team internal is your physician, it's your nurse, it's your case management, and it's effectively working to the top of your skill set and making sure that we're not overutilizing resources for licensures that, for instance, an RN might be doing just normal /, right? So and then it also extends out to looking at the different areas of care coordination and transformation of care within that practice or that patient
So examples would be your ER, looking at your outside care coordination entities, looking at hotels. So we want to make sure that we're always involving a complete team, not just a partial team. You're welcome. Is there any thoughts on that? Any questions? Okay. This is the medication demonstration project area. So I wanted to make sure that we understood how each one of these relate to each other. Okay. Bidirectional integration. So every single one of the PCMH tools or implementation plans is exactly the same with the exception of the bidirectional. Each one of them cross-apply to risk stratification, empanelment, population management, care coordination, evidence-based medicine, and enhanced access, community and stakeholder agreements. Carol did an excellent job of adding on to the spreadsheet. We'll go over that in later discussions. Defining actions, access and continuity. Because healthcare needs and emergencies are not restricted to office operating hours, so we want to make sure that we are not restricting ourselves within the hours of normal operations, Monday, Friday, 5. Want to look at our patients and what their needs are. Claim care for chronic conditions and preventative care, participating primary care practices proactively assess the patients, determine their needs, and provide appropriate and timely chronic and preventative care. So what we would do is look at paneling, making sure that you understand what your provider base is, and make sure that they have the accessibility to be able to treat those patients. Risk stratified care management, patients with serious or multiple medical conditions that need extra support to ensure they're getting the medical care and or medications that they need. So identifying those high-risk patients and being able to risk stratify them, create a solution that works within your practice. Coordination of care across the medical neighborhood. Practices work closely with patients' healthcare providers, coordinating managing care transitions, referrals, and information exchange. So it takes a village, not just a small team, right? Assess and align. In any medical setting, whether you assess using the patient-centered medical home, the PCMH model, or the main Health Access Foundation assessment, MEHAP, the practice transformation approaches contribute to overall better patient care and improved success in value-based reporting and reimbursement. So that's the end value and the reward for the physician. Not only do you get to make sure that you're managing your patient population effectively, but it also creates an incentive to be able to meet those metrics. Value-based care. Value-based care models center on patient outcomes. How well healthcare providers improve quality of care based on specific measures, reducing hospital admissions, using certified health IT, and improving preventative care. Do you have any questions on that? The most common measures in value-based reimbursement contracts remain the same year to year. Follow-up after hospitalization, emergency room use, readmission rates. For most provider organization executives, these constitute a must-have. And it hasn't changed, guys. It's been the same for a long time. It's not a new concept at all. Top 3 needs for value-based reimbursement: sustainability, more and better reporting for managing value-based contracts, and technology infrastructure that support value-based reimbursement. Management talent with the expertise to use that. So leadership is a key component, and so make sure that we have the resources and the leadership to empower those different clinics to make sure that, or entities, to make sure that we're doing transformation efforts effectively. Technology infrastructure. I can tell you by going out and doing an assessment on all of these different entities, and as well as with the CSAs that were submitted, there is a lot of infrastructure and capabilities that are lacking. You guys have any questions on that? Key to winning the buy into value shift. Know your partners, put physicians in charge, support data-driven decisions, and make worth their while. Be transparent and provide the tools for success. So in our practice transformation work group, we were looking at put physicians in charge. What does that mean? It means giving them the tools and resources to be able to assess their patients actively and proactively to ensure that we're making better outcomes for them.
Can I interrupt? I would challenge that. Because I think team-based care is not at all about putting physicians in charge.
Right.
No, but if
Does anybody else agree with
I agree with you. It's really not the physician. There's other key players on the team that would need to be driving that.
No. They're all a team, but as far as the physician themselves, being able to, so what comes back to value-based medicine or reimbursement, physician themselves, right? The entity. So if the provider is not supporting or leading that team, then they're not going to be successful, right?
I think it happens the other way around. The team drives the provider, not the provider drives the team.
Oh, I agree with that, but the thing is being
If
able
the
to.
strength of the care plan is a behavioral health care plan, that provider,
Mhm.
then you're not true.
Mhm.
The behavioral health team should have a lead role that the provider endorses and supports.
So what comes back to the value-based reimbursement? It's the provider's name that's the one that's the provider. Does that make more sense?
No.
I don't think
We
we're
may have to agree and disagree, because I don't think you're going to convince those that
No,
are.
I believe that the team supports and actually takes a lot off of the physician's plate, which also increases satisfaction, definitely. And I think it takes the team to be able to assess the patient and manage them proactively. The only thing that I'm saying is whenever the healthcare authority is looking at whose name is the rendering provider, it's that physician.
Yeah, but I think what we're saying is they're wrong because that's true under volume. It's not true under value.
Yeah.
Okay.
Given the flexible,
Put your phones on mute, please, if you're not speaking. We've got quite a bit of background noise. Thank you.
if the provider, after the treatment that needs to be provided, that you don't have, like, somebody denying the payment for that, is that what you're trying to?
Correct.
To convey?
Correct.
But not necessarily that they're the drivers of what happens with that client.
Right.
Maybe it's just wording.
Yeah.
I think the wording is.
I took it directly from this website here, as far as their terminology, that when I read the definitions and how they described it, they said that being the name on there, as far as the value-based reimbursement, it's contributed back to the
Challenges, we did a presentation with Cadillac Hospital and outpatient services. And one of the questions to them was, do you as outpatient physicians want to be the responsible party for behavioral health care delivery? And they all shook their head and said, no, that's not what we're talking about. And that's what you have on the board. So I don't know that you've got the buy-in from even the people that are being identified as tag, you're now in charge.
But the metrics are tied back. That's all I'm saying is the metrics are tied back to that provider. So if we're not proactively working as a team, then we're not going to be successful, right?
May not be successful if you
Yeah, I agree with that, and I'll change that. I just take it directly from the website that, like I said, the definition is based upon metrics, what that looks like in the reimbursement.
Empanelment is a very big issue here in terms of, as Sam was talking about, assigning accountability to those particularly important measures. Ultimately, they roll up to the primary care practitioner, whether it's
not in the case of MSW using behavioral health care, but independent Medicare numbers
And
that
not
are
in the case,
independent practitioners.
and not in the case of community health centers, they tie back to our tax ID number.
Right.
So it's not an individual practice.
So what's an alternative to the, what's the opposite of put physicians in charge? What's the opposite of that?
Are you asking me? Yeah. What's the opposite? Well, nobody. Nobody?
So is that what they're trying to convey? There's 1% or 1.1?
No. The point percent, just that, that value-based reimbursement, it was tying back into how that PCP, their name is on there as reimbursement.
Charge to them, like, the hierarchy of keeping the right, the better.
So most of us didn't hear what Janet just said.
Oh, I'm sorry. I said maybe keeping them engaged might be a better choice of words, because keeping them in charge kind of denotes like a hierarchy, like I'm your PCP, I'm Dr. So-and-so, you do what I say, but rather keeping them engaged.
Mhm.
And I think that that's important, sometimes for the man, to be able to look at the mechanics of that, because whenever we were looking at how that relates back to PCT, and we were informed that the PCT, even though the metric is looked at how it's reported, and not only are it's by zip code as opposed to the provider panel, but when we're receiving the information, it's always by provider panel, and that's the metric that we get to utilization or overutilization and the reporting for. So that's what can help.
Well, we have a couple of MCOs.
Yeah, can you help us with that?
Can you re-summarize what?
Whenever the metric that you're utilizing for the MCOs, how is that tied in? Who's responsible for that? Does it tie back into just the overall tax ID, or is it tied back into the provider that's rendering services, or the PCT and panel?
I'd have to check where they're falling in. I think we have a variety of way that it's pulled or it's submitted. I know Caitlin is on the phone. She may not be able to answer. Maybe I can follow up with her. You know,
But I can tell you, because as a primary care provider, our contract, our metrics come back to us at the clinic.
Right.
And our rewards and our incentives are we make it or break it at the clinic, not for each individual.
yeah,
Right.
so I don't know if it's like GI or.
It's tied in our tax ID.
Yeah.
So as a Department of Health and Human Services, whenever we receive those metrics and the initiatives to be able to make it tied back to the PCP. So we probably need to be able to talk to them about that.
PCT has specific tax ID as well. We can follow up on it.
Okay. Yeah, that would be great, because we want to make sure that we're doing apples to apples, right? To make sure that we're moving the metrics appropriately.
Just, the other piece I would throw in is with the healthcare authority in our alternative payment methodology, they're measuring us by an organization and not by individual.
Interesting to know, because Wes and I had a opportunity to discuss with them on how those metrics, and they really want it down to the provided level, if not the organization.
We report by the organization.
Yeah.
I don't know.
I think you're good.
We have to find another 1.2 billion to get us to get down to that level with everything else they want us to do. That's how much it'll cost, and just being able to get you that reporting.
That would make sense when we're having such a huge issue with impoundment.
Right.
Information, I hope there's a bunch. I think we need to go back to the table and look at how we're going to do our metrics. All right. So within our next meeting is detailed information on the transformation approaches, detailed information on the transformation project implementation planning, and detailed information on maximizing reimbursement. Any questions on that?
So this is basically a presentation that the practice transformation work group got that Wanda wanted to just put on the table for the rest of the board. Is keep talking about practice transformation, and so we're just trying to clarify for everyone what it really means.
Any questions? And I appreciate the information, because definitely I think we will have to look at the metrics and how we're going to be addressed. We really truly have been talking about how they look at empanelment and what that means for this metric, but they're wanting to provide a level. And within our region, I noticed that it is more focused to the zip code. So basically, our providers might not even treat that patient, and there's a lot of patients who go across the line to actually have services, but the Greater Columbia ACH is responsible for the patient. A little bit of information on that.
I just think the more clarity is, the more in alignment it is with the reality. It helps us help you meet your goal, because otherwise
I agree.
we're not working for the same things.
Right, and making sure that we're knowing how we can meet those metrics, right? I appreciate that information. I'll keep it back to
building group, which are all the ED directors across the state, and we're looking at legislative issues as it relates to workforce. So one of the things we talked about was what is team-based care? What is the model? What is the definition of that? So that if we think that that is an important element that needs to be reimbursable in the future for the sustainability of our model, then we need to identify that. So that's why I asked Sam the question, because nobody really has that definition yet. So that will be one of the things that we will have to work on if we want to put sustainability into this project, because GCACH model is obviously team-based, right? So unless we can reimburse for that, and maybe Sarah, you guys can answer this question, what elements of team-based care are actually reimbursed at this point? So you're saying it's based on the contract, the negotiation between the provider and the MCO? Yeah. Oh, you're submitting for that. It's a very broad degree of care that can be further defined. And so, and the Courtney's statement is based on the actual services that are being delivered within that team.
Okay, anything else, any other comments? Transformation, anything like to make? Then I think we're going on to, oh, you know what, I skipped over the report, Carol.
Okay.
Sorry.
And is Kylie, have you joined us yet, Kylie?
Yeah, I'm on.
So I might allow Kylie to go ahead next because she's over in the office preparing for the audit. And so they're asking her to pull a whole bunch of samples. And so she wanted to do that today because she's out of the office tomorrow. So she needs to get kind of done soon. So we allow her to go next with all the financial reports. Hey, Kylie.
Okay. So first up on the docket is the balance sheet, and you can see that we have the $120,823 in our checkings and the $6,488,000 in our money market. So total balance is the $6,609,000 currently. And there's nothing out of the ordinary as far as liabilities and equity. So if we move on to the budget versus actual. You notice it on the revenue, so you will see the new source, the $966,000, which came from the district incentive funding. So we pulled down that funding to pay for our admin. So we have a total revenue of the $7,151,000. To date, from January to now, we have made a total of $27,000 in investments just on interest in our money market. The expenditures in the design funding, we've spent a total of $470,793, which is a 26% burn rate compared to the budget amount that we have for this year. Like I said before, we're now running payroll out of the district incentive funding, and we just started that this month. So you can see the payroll charges thus far, it's only 3% of the total. We have the $20,000 from a mayor group that we haven't touched yet. And we still haven't really spent any from the Yakima Valley Foundation funding. We have the total expenditures in all categories, $502,093.18. And if you want to see a complete roll-up, there's all the way at the bottom there, a roll-up of all our categories between all of the different accounts. And moving on to the May statement of activity. So like I mentioned in the budget versus actuals, we have revenue, the $966,000 that we pulled in that you'll see up there. So that's new. $6,460 on the interest from the money market last month. Out of the ordinary costs, we have the $12,269 that was paid to OHSU for all the work that they've been doing with us as far as the CSA and meetings. You'll see $45,000 under the 2B engagement for the LINs. We paid $30,000 in full to the Benton Franklin LIN and $15,000 to the Southeast Washington LIN for their deliverables. There's payroll and another little out of the ordinary. The office supplies is a little high. We've been gearing up for the 2 practice transformation navigators that we have onboarding. And we have paid Rob Arnold with our HIE contract. He hit milestone 2, so that was $5,000 there for the total expenditure of $139,880. Is there any questions on any of the financial reports?
Doesn't look like it. And Brian, are you still with us?
I am still with you, yes. We're good. That was the...
Actually, comes forward as a seconded motion to approve and accept and approve the adoption.
Correct.
All right, Brian.
That's all right. Thank you.
Okay, so we have a motion by Brian and a second by Ed from the Finance Committee to accept the financial report and to accept as presented. Did I do that right? Okay.
I think you're doing that correctly.
Okay. Trying to get this down. So is there any discussion or questions? Not, then all in favor?
Aye.
Any opposed? I think that was a
Kind of like.
Any abstentions? Okay, thank you, Kylie.
Thanks, Kylie. I just read that.
Yeah.
Motion by Brian, seconded by Ed, to accept certification compliance.
There wasn't a recommendation.
Okay.
It was just the financials as
The
presented.
financial. That's why we said that loud. Thank you.
Thank you. Great. Okay, back to Carol.
Okay. So, the June GCACH report has a kind of a new look. Lauren has taken this to the next level. It's really nice. It's like the first article should have said practice transformation. I was running the same project transformation. I must have been project centric in my head. But again, it's just going back to what is practice transformation being the foundation of the way that we are framing all of our projects. And then I included just a couple of quotes about practice transformation from the CSAs that we got. So you'll see a quote there from the Yakima Valley Farm Workers, and then Mike Maples, I thought, had a very eloquent quote about how CHCW has used practice transformation and how it's enabling them to expand patient care. I'd also report for Kylie is that we continue to, and Diane's here too. So Diane, you want to make a report? Sure. Okay. We School Bar made paid 44 organizations, total of $144,000. Those are for the LOI, the registration total, and whether they were project facilitator or education support. The next unit is the 29th, and then based on there, there's another section in here that Charlie will probably go over the provider engagement training formula. And so we'll talk about that. But there's still 18 providers that still have not registered in the portal. So we kind of need, there's some key players in there that really need to get their registrations done. So still meeting them. So hopefully we'll get them the link we need. And some of that I think is due to transition, for example, Lord being purchased by GCACH, and they're going through some issues. And I think the Yakima Nation is still working on their registration with the portal. So we're continuing to work with all of them. The links, the deliverables, as you can see, the little piggy bank was distributed money to the VFTHA, Kittitas County
forward with all the teams to go in. Dan, do you want to talk about practice transformation training? Excellent.
I knew it. She actually just almost completed it.
The microphone.
Yeah, so I have gone through 32 modules of practice transformation training. Anybody who lets me know that I have a binder that's ridiculously huge and named it Leslie because it's so big and needed a name. But in that training, it was geared toward the practice facilitator, as they call it, or the practice transformation navigator, tools that we would use to engage practices that were going in, skills, things like PDSA cycles, appreciative inquiry, things like that, and also did some reading on the Safety Net Medical Home Initiative and their culture for change. And with that, that's a little more geared towards the practice. So if a practice was trying to become a patient-centered medical home, things that they would use. So those two trainings I said in my summary were very complimentary for me, how to things that a practice would be looking at, things that I as a practice transformation navigator would be looking to go into and explain and help and guide and all those other ones.
Of course, initially, practices both are reviewed. We'll pass the microphone down to Ruben.
Yeah. All right, so I attended the Yakima Nation Treaty Days on June 8th, and I love it. I felt at home. I had a good time. I took my 12-year-old daughter. You can see I took a bunch of pictures, and this is the parade. I had Indian tacos for the first time. They are delicious. They're amazingly delicious. So yes, this is a celebration marking the anniversary of the treaty of 1855, where the Yakima Nation ceded to the federal government over 12 million acres. And you can see the map there, pretty much the extent of the Yakima Nation that reached all the way over here. And then you see what it was reduced to. So yes, we had a great time, and I learned in several meetings that the word reservation, as it pertains to the indigenous people of the United States, it means the land they reserve for themselves after ceding land to the federal government.
Lauren, do you want to talk about your attitude?
Sure. So through Magnitude, I created a map that illustrates all of the organizations we receive PSAs from. So as you can see, it was very spread out throughout our entire region. There were several in Yakima, several in Tri-Cities. You can also reference the key, and that shows which it's color-coded by sector, so you can see which dots represent which sector. And we received a total of 55 PSAs.
Does this map, does this represent the totality of our region? Or am I saying that right?
I think it actually goes a little bit further
Yeah,
up.
I think it goes a little bit
To
further.
Cleo and a little bit further west to GCACH. More of the reservations that, yeah.
Yeah, there's a bit of the Yakima Nation that is cut off, but I realized it's pretty small, so I wanted to try and get as big as I could to highlight all those dots, but there aren't any dots outside this map.
It's a great graph.
If you were to zero in on those concentrated dots, they would disperse.
Yeah.
Just because it's such a high level, they congregate and they overlap each other, so it's hard to see all of them.
So Connell is in our region.
Yeah.
Yeah. But no, we don't have any operating from
Othello's got a green dot. It's CBHA.
Yeah, it's marked by Othello, but their clinic is really in Connell.
Right. It's tagged to their address in the city.
Yes.
Is there any layers of data on this, or is it just mainly the location?
Just the location.
So Monticello isn't it a
They have a site in Connell, so their Connell site, they are in our ACH.
No.
Yeah, no. No,
I'll come out to North Carolina.
no, they're in BHT.
Would this be used for data information, like research or anything of that nature, or it's mainly just?
Yeah, Wes and I are slowly working towards creating more maps based off of the CSAs in particular. This is only the second map we've had a chance to create, but we are hoping to create several more. More to come.
Mm-hmm.
So now, additional categories for engagement funding. Kylie, you going to do this?
Yeah. Kylie, are you still there?
Yep, still here.
Provided for data.
Okay. So hopefully you guys see the document titled Provider Engagement Funding Formula Approvals. You can see that it went through the Budget and Fund Flow Committee's recommendation to the Finance Committee, who motioned to approve or approved. So we have 4 categories that fall under the engagement funding, which was at $7 million that we're looking for board approval on. So the first category is the current state assessment submission, which obviously we've received. I think we have 56 now or 57, but we're wanting to pay out $1,000 for those that submitted those to us. Reason behind that is just compensation for the time that it took to fill out that 110 question document. And the next category is the practice transformation work group members. So the organization that the member belongs to would receive the $15,000, and right now we have 23 members total. And the way that we came up with that is we took the member in their position and looked at their annual salary and the amount of hours that they'll be putting in within the biweekly meetings and the homework they get from that, and that's how we came up with the $15,000. The next category is quality improvement team, which is another $15,000, and this would be only available to those clinics or providers that we actually contracted with. And this is going to be the team that's built for practice transformation that will be working with Sam, Jenna, Martine, and that includes anyone from HR, IT, admin. It's just going to be the group that works with them essentially. And the next category is the direct messaging, which for right now, we just have the price for the non-Medicaid only, and we had 25 non-Medicaid providers. We're requesting $1,000. So we got a quote for direct messaging, such as Allscripts, and found out that it's about $400 for initial setup. And then we figured for about 20 providers, it would provide an annual direct messaging cost for them. So just assuming if we were to pay out all of these 100%, everyone wanted it, completed it, then the total would be $755,000.
Hey, Kylie, it's Caitlin. I have a quick question on the practice transformation work group one. Because we have 2 MCOs on there, I just want to make sure that they weren't factored in the amount of money. I didn't know if that affected your budget at all, but since we can't receive transformation dollars, I just wanted to make sure.
We did not factor those in.
Other questions? Board?
Is everybody familiar with direct messaging? You want to explain a little bit about direct messaging, Sam?
Yes. Direct messaging is a social network, much like Outlook.
Microphone.
That works much like Outlook, but it's a national initiative that started approximately 3 years ago, started in New York, as well as implemented in Kansas and I think Oklahoma, but it's spread universally. A email base where you can actually send documents to each other and communicate even with the community network. But it
how does that work for non-provider?
Non-provider organizations, they would insert their email. It would be an address list, just like you would for Outlook or any other email system. And you can send them documents in a PDF file. You can send them images. You can send them referral information as well as demographics. Again, in PDF files, and they'd be able to access those.
Any questions from the board on the provider engagement funding board?
I actually had one more question, just a point of clarification. On the practice transformation work group, that is, it's the 23 members, but there's one member per organization. We don't have organizations that would have two, or do we do? If we have two, does any organization have more than one member represented on that?
I would say that Providence, so Mark Wakai, who is the Mark of our co-chairs, he's representing the Providence system, that Bill Dunwoody is representing Cadillac. So that would be the only.
So we would take two, or we take
Didn't we actually receive an incentive for?
They have two separate EINs, so that they would be paid.
Okay, so this comes recommendation. Recommendations from the Budget and Funds Flow Committee and recommended from the Finance Committee. We didn't make a motion.
Well, it comes forward as a second motion.
Okay.
And so you can move right to discussion and call the question.
Okay. So this has been moved by Brian, seconded by Ed from the Finance Committee. And so is there any further discussion on this? And so this would be one of those that if anybody is potentially receiving these funds, those board members should abstain. So all in favor? Any opposed? And any abstention?
Aye.
Aye.
Sandra, Rhonda, Ed, and
And Megan.
Megan. And Megan. We have no. Okay, Jim Avery, is he?
Avery, would be represented by Lily Gonzalez, right?
So Jim.
You have to abstain. I'm not sure Megan would have to abstain. Megan, I'm not sure that you would have to abstain.
Oh, okay. Well, then I vote for. Then I'll vote in favor.
Okay, thank you.
Yep.
And this is Caitlin. I was an I too.
So not on this one. No, you're right.
So she didn't do it at CSA?
Right?
They submitted it.
Right.
Right. But this is money going to the practice transformation.
No, I thought we were approving this whole thing.
Probably everybody.
Everybody would have to abstain. I don't. So do we need to abstain if we're really voting on something that's across the board? It's not. There's no unfair advantage to any one of our organizations. I don't know that we technically would have a true conflict. Or we move forward knowing that and accepting that folks voting completed a CSA.
Which I think is what we
It's what we've done previously. So do we need to revote that?
So let's revote them. So why don't you make a new motion?
I motion that we approve the provider engagement funding formula as outlined by Kylie on this document. Done.
Somebody second that? Okay, all in favor?
Aye.
Any opposed?
Aye, I'm done.
Okay. Any opposed? Any abstention? Okay, okay, thank you. Sorry. All right, the next thing is the mid-adopter funding for behavioral health.
So, a situation analysis recommendation went out to the board of directors, and this is regarding the integration incentive funding that is a separate category in our budget. It's about $4.07 million. And the recommendation from the provider organizations who met with us on May 10th was that this funding be distributed based on a funding formula that came from Greater Columbia Behavioral Health. So what we did is we contacted Greater Columbia Behavioral Health to get what that allocation would look like for this amount of money, which is before you today. And the providers also recommended to set aside 15% as a contingency fund in the event that one of the provider organizations needed some additional technical assistance, or should there be a desire for a group of the providers to get some outside expertise. And then we are also asking for a small administrative amount, because it will be up to Greater Columbia GCACH to put together the final implementation report and to project manage the project team. So in a nutshell, that's what the SBAR reveals. On the second page is the actual integration incentive funding that is broken out by provider for mental health, and then some are substance use disorder payments, and some organizations have both categories. So for example, Barnes Clinic is an STD provider, and in this distribution they would receive $33,000. And this is taking into account their net after taking out the reserve for CA and GCACH administration. So the recommendation coming from the staff is that you allocate the proposed funding distribution, you set aside the 15%, and you allocate the $68,000 for administrative expenses and distribute to the providers. I also included, as part of this, a recommendation from the staff that we just don't simply give out this money, because we need to be accountable to it. We need to be careful stewards of our resources. And so we're suggesting that each organization that we allocate funding to sign a memorandum of agreement. It basically outlines the expectations from the healthcare authority within the document. And then we would fill in all of the different funding amounts. Probably unique to this is we reserve the right to go into each organization and do an audit to make sure that they are spending the funds appropriately. And there's a large list, a list of 13 items that the healthcare authority has written out. I think it's fairly broad. We could ask some of our provider organizations if those are untenable expectations for the healthcare authority, but it includes such payments to increase capacity, for our IT infrastructure, for technical assistance, for a tax set aside, add additional staff. So I think it's a fairly broad list. So we don't think it's going to be a problem for the organizations to be able to show this, but we just felt like we just don't want to hand money out without having some expectation of what it's going to be. So we're recommending. So we're just recommending that this should be a part of that motion.
So we open for comments. This to me, so I have a couple of just comments on this in general. I think you reflected the recommendation very well. My only concern is that the group of providers did not limit the use of the contingency to technical assistance as delivered by the GCACH. It was a set-aside contingency to meet to deal with any of the barriers. So, and that could mean a local recruitment retention barrier that Columbia County had, but there'd be a mechanism to release the contingency to support them. So that's kind of my first objection, is add a layer of restriction in that. The second is our understanding from the HCA representatives who were there when we held the meeting. In the letter they have, the 13 elements were not full and complete. There was language in that list that said may include these 13 items, but left it open to include other items. So the memorandum language that you've proposed here is more restrictive than the state. My third objection is that HCA made it very clear to the providers that this funding was earned by the providers of the region with the act of going mid-adopter. The evidence of that action is contained in this packet in the form of 2 letters from the BHO to a healthcare authority. So the funding has been earned already. So for the ACH to assert that it has legal standing to add additional terms and conditions is false. It's not true. However, I do believe that we'll be successful by being collaborative. And so I believe that you can rewrite the memorandum of agreement to truly reflect a memorandum of agreement between partners, not the imposing of contractual standards. And those are my initial objections.
This is Caitlin. I just have a quick question. I think that, so the full amount wasn't earned yet. Is that correct? Because I think it was something like 60% of the incentive dollars are earned only once the region actually goes live in January 1st, or did the healthcare authority change that? I know that was the case at one point, but they may have changed something.
That's still true. The total cash value is a little over 10 million. This first dispersal of 4 million is what this formula speaks to. And that was earned by going mid-adopter. However, it was explained to us by healthcare authority there's a potential $6 million disbursement that will be available in May of 2019 if the region actually moves into integrated managed care. So there's a second release coming. So I think it's really important that we have a collaborative approach to this in this first disbursement to not create an antagonistic relationship with the provider network going through the implementation process.
So that's really sort of where my question was going is specifically as an outsider. There really are no deliverables for this money?
Other than imposed by the ACH in the context of this agreement.
And do you agree with that?
Every ACH is different. That's why I included the minutes from all of the other ACHs. So some ACHs, like for example, Northbound, they're taking all of their incentive spending and they're putting it into their behavioral health integration class because they have a very collaborative arrangement with their BHO that was willing to work with them to figure out how this fund is supposed to go. I think we're the only ones that are allocating it through a formula to the BHO. Some are not distributing nearly as much to some of their behavioral health providers. Some are not even limiting it to just only BHO providers. So I think everybody is approaching this somewhat differently. So it's really up to the board to decide how they want to distribute the funds. But clearly the decision on how to allocate the funding rests with the ACH Board of Directors, although it is absolutely right in the way that it was earned was through the signing by all of the county commissioners who then agreed to go mid-adopter. So that's why you have the materials of the letter, the binding letter sent from the county commissioners, the letter from Banca and Mike Bernie that's presented in this packet as well. And then healthcare authority does have expectations of how this spending should be used. That has been widely distributed, and so that document is also a part of this package.
Carol, did you, once you wrote up this proposal, did you go back to the behavioral health organization to get input?
No, we haven't had an opportunity to meet yet. We were going to try to meet today, but it just was too crazy. So the behavioral health providers are coming together on the 20th.
I was just going to say, the provider meeting that we have created and hoping to keep ongoing was really a chance for the first time for providers to come together and really look at the needs that we have and the use of the mid-adopter dollars. And so we did come together and talk about our needs. And one of the things we're doing, each provider is going back to look at the needs our agencies have and where we'd like to utilize the funds. And one of the things in the letter is it's difficult to decide right away where our biggest need as providers are, because we don't know some of the expectations that we will have in regards to healthcare authority and managed care organizations and data, et cetera. So as providers, we agreed that at this time what's worked for us in our region is the way the formula has ran through the dollars. And that's kind of the best, fairest route to do it is what's worked in the past. And again, there's a lot of work with transition and everything else. So to hear, audits and coming, that kind of cringes. Like we were kind of told this is what you get for adopting and being a mid-adopter. So we did put in the letter that we submitted for review that our plan on the 28th, when we come back together as providers, is to discuss not only the second part of the dollars that will be distributed, but also the agencies are supposed to come back with kind of what they saw their own agency's needs were. And the hope there was we would come up with, okay, this is what this person's going to use it for, this is what this person's going to use it for, because we understand the accountability piece. And again, it's hard to decide right now for some providers what will be the biggest need, because we're right in the middle of, changing over. And so the expectations for MCOs, et cetera, is not always clear and from the healthcare authority. But we said in the letter, we're open to, if we need to do some type of narrative form back to you as a board, et cetera. We just don't want it to become another huge task for providers, especially when we move forward with 3 to 4 different MCOs that we'll be working with now, as well as continuing on with our BHO.
Also, didn't want it to become a binding obligation that could be changed at a later date. The other thing that hasn't been discussed yet is the providers proposed, understanding that GCACH has an obligation to have an implementation plan in place with relatively short order. And so there was dialogue about the event that would trigger the release of the funding to the enrolled agency would be the submission of the self-assessment and initial investment plan, so that we were giving a product back to the ACH to let them complete their obligation. So there was a mechanism recommended in place for that. Again, my opposition is that as it's written now, it grants standing and to an organization that doesn't have, and we would be really reluctant to enter into it. However, do recognize the value of partnership and collaboration. And so if that language is softened to more reflect the collaborative nature of the agreement, I think that's something we want to go forward with.
So there's a couple of other documents that relate to this that you can in the package, and so I don't know if everyone's had a chance to look at it. Can you give us a kind of a high level overview of what these are?
Sure. So the first one is where we really put a lot of the pieces that are in the contract is the expectations regarding use of Medicaid transformation integration incentive funding. And this is written by the healthcare authority as what they have seen across the region, how they envision these millions of dollars to be used across the state. So they articulate that the funds to be used to assist Medicaid behavioral health providers in the uptake of new billing or electronic health record systems, technical assistance to behavioral health providers or substance use providers who are not accustomed to conducting traditional Medicaid billing against behavioral health results. Technical assistance for providers who work within managed care business processes. Funding to support the hiring of temporary staff to assist with historical data conversion at Medicaid behavioral health agencies or reconfiguration of billing systems. Providing Medicaid behavioral health providers with funds as an incentive for completion of the flawless self-assessment tool. To provide funds to Medicaid behavioral health providers to cover operating expenses for the first quarter of IMC implementation, so that providers have adequate cash flows during the initial transition months. Funding to support provider recruitment and retention, and incentive funding for provider participation to improve provider network, funding to support specialized provider training, using funds to build upon or improve a quality improvement program, and funding to support and build upon the reason for integrated clinical model. Next page, support for behavioral health providers to attend training and collaborative meetings with medical providers and other outside responsibilities to cover their timelines from patient care. Funding for pilots at clinic locations, like, for example, obtaining substance use disorder consent and recognition. So it was the healthcare authority that came up with this fairly comprehensive list that, from what we could tell, was very consistent with what the provider organizations were considering within their letter. So the next page is dated May 30th.
Carol, may I add
Sure.
briefly? So when you look at this document, you reference this as a portion of the contract, but it's not labeled as an appendix to a contract? Or is this a guiding document from HCA?
This is a guiding document.
Okay, so it's not part of your contract related to the funding or any verbal or other contractual agreement between the providers and GCACH. The other thing is, if you look at this document, it says it could be used for these things. The memorandum of agreement limits it to these things, and that's a difference.
Yeah.
It becomes more restrictive.
Just want to walk us through the rest of the document, okay?
Okay, I just have some concerns here.
Okay, no, I understand you do. I just want to make sure the board has a picture of everything we're working with. Then we'll come back.
Okay.
So the next document is the letter that we received from Danica. By the way, this is Danica.
Hi.
And she and Mike Burney were kind of the leads, the co-leads on this provider organization. And so they wrote this letter after they had met on May 10th to review the funding and to make recommendations on how it should be used. So she describes, and Danny, if you want to hit the highlights of the letter, you're more than welcome. Everybody to read this. So it was that this is regarding the healthcare 30 phase one, part of the total incentive funding, which was about $4 million. And so they suggest holding back the 50% of initial distribution of the contingency amount. Again, possibly to engage consultants to deal with any issues that may affect all the greater health behavioral GCACH providers rather than individual limbs. And then the remainder of 85% would be distributed to the providers according to the funding formula that the Greater Columbia Behavioral Health Organization. And then it was decided that the providers would evaluate their most pressing needs and create a plan that would, again, trigger the payment. And that they were talking about how they should be accountable to the funds. So their suggestion was that they would write quarterly reports that could be submitted to the Greater Columbia ACH, and that they intended to meet again to review our feedback regarding their proposal. So this is the first time the board has actually had the opportunity to look at your letter, and that you can take back our feedback on the June 28th. I think I hit the high point. Did I miss anything?
And this next one related to the.
And we literally did take what the healthcare authority had there. Isabel was there to talk about that it wasn't just those 13 things on the list, but I mean, a lot of us are working towards those. And we have providers who will take this money and hold it. So if a claim comes, 3 months of claims come through and they're not reimbursed because of some IT situation, back up for themselves. So.
And that's my primary objection. They reiterated multiple times that they anticipate cash flow concerns when you go into change. Some people may not have the cash on hand to withstand payments being related to them. And so that use is not on the restricted list in the memorandum of agreement. So.
And Isabel was the one who actually brought that one up as an example. So.
Is that number F in the?
It can be however you want to, cash flow, whatever.
Providing funds, Medicaid behavioral health providers to cover operating expenses in support of IMC. Is that kind of the set aside?
Similar, yeah.
So that providers have adequate cash flow during the initial transition. Then the next document is just the letter of intent that the county commissioners signed on October 27th. We didn't include all of their signatures, but it would have been a really long document. But approval by the Health Care Authority on October 16th, to say that you are an adopter. So we just included that information in your packet so that you guys could crosswalk between all of these different. So regarding the contract, if you want me to speak to that, I would just say that under allowable costs on page 2, section 4, the expectation is that the funding could be used for these things, and we even say that on page 1, it could be used for these things, but we reference the healthcare authority's expectations regarding use of Medicaid transformation, integration, and incentive funding. So I'm not exactly sure what you mean by that. It's not a reference to a document, but we put that in quotations, and that's what the document said. That document.
And so I think if you were to amend page 2, section 4, first paragraph, to read, to include but not limited to the following, you capture the spirit that was communicated by the HCA, but there could be other uses that are identified.
So I think there are two decision points that we have here. The first is who gets the money, and the second is whether or not how the money gets used, basically. So
the second is probably more accurately described as does the MCH have the legal standing to add additional terms and conditions to the distribution of these funds.
Well, that's a longer way of saying it, but
it lays a legal foundation, so it needs to be reflected.
So for the state, for the board, what I'm asking is, let's start by saying, does the board have any questions or comments about the first? Let's start with the first, the list of
This is a requirement for behavioral health. Does every provider have the same? Why is behavioral health different?
So this is a special pot of money for community behavioral health providers that have been contracted by the WHO that are transitioning to mid-adopter. In other words, they are transitioning prior to 2020 to be fully integrated with managed organizations. So this funding has been set aside specifically for that purpose because the state's goal is that 90% of all healthcare will be integrated with behavioral health. It's hard to integrate behavioral health and physical health until you have the billing system set up. So it facilitates bidirectional integration when you've got those billing processes. Is that right?
Pretty close. So prior to the decision to go to early adopter, what Carol's saying, that the funding for behavioral health care, substance abuse, and mental health in the state of Washington was a carve out within the Medicaid plan. And so there was a contract arrangement that the behavioral health organization and its provider groups accepted and bore the risk. And in Greater Columbia, it was done through a capitated payment system. So the decision to go into early adopter means we're going to abandon the system we've understood and operated within for 20 years. And you're going to impose a new financial structure to us with insurance companies between us and the state now. And so there's a change in the fundamental way that we'll do billing and we'll plan and make financial decisions. So we could have delayed that until 2020. The region said we're willing to go early to help the state meet its needs. And this payment helps us to prepare for that transition because it's a massive transition in how you organize your financial system and how you're prepared to do billing.
And we went to our commissioners, some of us, most people went and said, this is the way to go so that we can get help with this transitional period. So commissioners made votes at our behavioral health organization to do this, knowing that these dollars would be here and be given out.
How about on the phone? Does anybody have any questions?
No, this is Megan, and I've been part of this conversation for quite a while, and I think that it's been pretty well vetted through the why these dollars are available. And so I think that the sooner this decision is made on how to get them out and how much to who is really important for us to move forward with, because 2019 is coming really quickly, as is 2020. And so it's inevitable that this can happen. The faster we can make a decision, a well-informed decision, the better.
Yeah, and this is Brian. I'm just trying to stay current with the conversation. We're good.
This is Ronnie, and I do.
Okay, thank you, Ronnie. Welcome.
Thank you. I agree with Megan on that.
Okay. So
this is Dan, and I apologize for coming on late, but the call has been really gurgly, for lack of a better word, and I don't know if everybody else is anybody else is having problems hearing the conversation, but I'm wondering if I should call back in.
I'm having the same issues on this end, so I'm thinking that it's something about the connection from the office.
Okay, well, we will all try to speak up and see if that helps, Cindy. So let us know if we're fading away, and we'll try to do better. So I guess the question, first of all, let's start with the receivers, and let me ask if the board, if you feel like you have enough information to decide to make the decision if you support the funding formula and that the group has presented in terms of who receives the funding and how they can come up with a formula for the funding. Do people feel like they have enough information to make that decision to go forward? Let me say the reverse. Does anybody feel like they don't have enough information? Are you guys comfortable with the plan?
Mm-hmm. Yes, absolutely. My only objection, again, was the language of the agreement.
So we'll get to that next.
Right, but I'm just making it clear that I support not only the distribution formula, I also support there needs to be a collaborative document between the GCACH and the provider organizations.
Does anybody feel like they don't have enough information to make a decision about the funding formula and the distribution of the funds? Okay, so having heard no objections, would someone like to make a motion regarding the formula distribution?
I'll make a motion that we accept funding distribution and providers that were selected.
Okay. Is there a second?
I didn't hear the motion.
Lori made a motion that we accept the funding distribution as presented, and it was seconded by Terry.
Okay, thank you.
Is there any further discussion? If not, all in favor?
Aye.
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 Any opposed? Any opposed? Any abstentions?
Aye.
Aye.
Sandra and Ed. Okay, motion carries. So the second would be this regarding the memorandum of agreement or any memorandum of agreement. How would you like to proceed in terms of recommendations for an agreement? Do people feel like you have enough information, or would you like to ask Carol to get more information?
I have a recommendation.
Okay, Ed, go ahead.
So I would recommend we authorize the executive director to enter into memorandums of agreement and give her the authority to make whatever edits are necessary to the document to come into agreement with the provider without having to bring the document back to this board, provided that it maintains the intention to establish a collaborative relationship between the GCACH and providing.
Is that a motion?
No, not yet.
I saw Ashley was typing in the motion after this.
So we have a recommendation from Ed. Is there other information that people would like to have around this?
I have a question. So let's imagine we give comprehensive $1 million tomorrow. They, or next, in 6 months, for whatever reason, they run into financial difficulties and they are not able to use the funding because they are no longer a mental health agency. Or something else happens where an agency uses the funding to take their staff to Hawaii, you know? I mean, I think that we just need to have some reasonable assurances that the funding that is being from the tax dollars, it's not anybody's money, it's really the taxpayers that are funding Medicaid ultimately that is flowing down, just like all federal funds, right, that get passed through the state. So is there any sense that we shouldn't be somewhat accountable to the funds that we distribute? Even to the LINs, we have a memorandum of agreement and certain expectations of those funds that come from CMS to perform certain things. So I just want to make sure that we're protected as a board so that we're not just giving the money away without having some expectations on the other end. And that's what we go through the funding formula for the CSA, the LOI, the practice transformation work group. I mean, everything has somewhat of an expectation of performance to it. So I'm totally open to a kind of a collaborative agreement. I just want to protect our organization from just simply giving money to an organization without having any concept.
And this is the principle I think that we failed to communicate on. This money was earned by the provider network by adopting. It's been earned once. We don't have to earn it again from you. It needs to be distributed for the purposes that it was earned to carry out. Now we can work collaboratively with it, but what you're describing essentially is you hired me to mow your lawn. I mowed your lawn. You gave the money to Wes, and I have to go wash your dishes to get it.
But you haven't. I think if you've earned it and we give it to you, that's fine. But you have to report back how you used it.
And that's a memorandum of agreement. And that ultimately that report flows to the state, facilitated by the ACH. And that's my position. The ACH doesn't have the legal standing to add terms and conditions. They can help facilitate communication to the HCA what the funding was used for, what the plan was, and we ourselves have an obligation to deliver an implementation plan.
Is this our money? Is this GCACH money? Yes. And I think we do have to do this.
No, it wasn't. It was earned by the VHO, and that was quite clear by Healthcare Authority. Now the fiscal agent has become the ACH, but they did nothing to earn the funding, and they have no standing in how it's distributed. Now, if other ACH have opted to surrender or to give standing to their ACH, that's fine. This provider network did not actively make the decision to surrender authority to the ACH or grant them additional standing equal to the state in the distribution of funds.
How hard would it be for us to get this clarified to Healthcare Authority?
Not very.
I think that would be. I think we do have an obligation to get this clarified. Yeah. And if they say you have no obligation, then we have no obligation. But if the money's going through our account, I can't believe we don't have some responsibility.
It's already been earned.
Just saying, Ed. I've worked in this world for a long time. If the money goes through our account, somebody's going to look at it and say what to do with this money. And if the Healthcare Authority can give us something that says we don't have any responsibility for it, then
I think they will give you the statement that it's been earned by the regional providers can come up with a plan. The issue here is Healthcare Authority directly negotiated with 9 elected officials in Southeast Washington, and this is the impression that they gave when they upheld further conversations. For them to have changed how that's delivered without consultation with those 9 elected officials, I think is a significant concern.
So I would be concerned that we might have a legal challenge if we don't go back to both get clarification from the HCA and our association negotiates all the time with the state on our contract, even though by legislation, we're the vendors, we're the vendors for Medicaid, Title 19 case management. So, but we negotiate as an association with with the state. And ultimately, the state has the right, and we have the right not to sign it. So ultimately, the state has the right to what ends up in the contract, but they usually, try to iron out some of the minor issues so that the relationship is solid. So that would be my input. That maybe, I don't know that you're going to want to have, I don't know how many providers are there. I don't know that you're going to want to have 17 very memorandums of understanding, but you might want to go back to the provider group and see where if there's some consensus around some of the issues that Ed and Danica have mentioned. Did the money come from the HCA? We give the money back to the HCA. That's who has the contract with them.
So I'm thinking, Carol, that maybe you and I and Isabel can sit down and just have this conversation. And then on the 28th, when providers and healthcare authorities there, we can finish up anything that may be
still sitting. Yeah. It was Caitlin Thappery last month that said we do not want to delay getting this money out to the providers. You all remember that, right? Right. And so we scrambled to get this together. And we, to the best of my knowledge, we are just trying to use the language that all of you providers have been getting from the healthcare authority, which were the expectations. That's really the only guidance that we had was this is the expectation from the healthcare authority. And this document has been widely used as providers. This is what we expect you to use it for, right? So I was just, and if we're trying to get ready for, integration by 2019, if the money isn't used this way and we have a bunch of providers that are not ready, then it's really our head that the healthcare authority is going to go after, even though the money has perhaps been distributed. So I am just trying to protect this organization to say that this money will be used appropriately. I mean, there are a list of allowable and unallowable expenses from the federal government. So we don't want the providers to think, well, this is our earned money, we're just going to go have a party with it. And I don't think that's your expectation either. We're all reasonable adults here, but just from my point of view, there has to be something that the board of directors can hang their hat on when they say, yes, we are using these resources wisely. Now, maybe that's an overreach, but I don't think so because that's been very consistent with even the money that we've been giving to Lynn. We're not just giving it away. We are having some expectations put on them in terms of, creating some kind of consumer feedback and taking regular minutes of their meetings and things like that. I don't think we're trying to be unreasonable with any of these expectations. It's just that we're trying to protect the organization so that at the end of the day, and here it is December 31st, and there's 9 organizations that aren't ready for fully integrated managed care, then we haven't done our job as an ACH in getting those providers ready. And so I just want to make sure that everybody's on the same page.
Yeah, I don't disagree with you, Carol, about there perhaps needing to be some accountability level. The difference between the LINs and this is the state passing on their responsibility to you without giving you guidance. So I think you've done the best you can. The problem is this is all written in fairly wishy-washy language, and so to then put it into language that isn't wishy-washy but very clear and direct, I think that's where the challenge is, and I think the best is to get clarification to the state because I agree with what you're trying to do. I don't blame you for wanting to do that. I think that maybe we just need that extra guidance from the state as to, is that a step you have to do with this? Does it need to be written for this portion a certain way and the 60% a different way? We don't have clear guidance from that, and I think that's not your fault. I think that's the HCA's fault. And so if we could if it's something that is seemingly easy that could be fixed up, then now's the opportunity to fix it.
Well, I would say probably both.
Yeah.
Well, get us to where we need to get is getting clarification. Getting clarification from the state and working with the provider group to find something that doesn't cause heartburn for that responsibility is in terms of this, for this organization, for this board.
And I think, that can happen very quickly. It can happen with a phone call to the HCA, a meeting between us, and then presented to providers on the 28th. So we're going to be moving quickly.
I think, and for our purposes, I think we want something in writing from you.
This is Caitlin. I think having something in writing would be good, and I think we would just recommend that Rhonda, you be a part of that meeting as well from a board perspective, just because fiscally you're the one, not you in particular, but the board is fiscally responsible for the money. And we have multiple people hearing what they're saying and then getting it in writing, I think is really helpful.
I would be happy to. Thanks. So before we leave this, one other question is, does the board want to review a final MOU, or do you want to tell Carol? Well, maybe I should ask Carol first. Are you comfortable going forward with developing a new MOU, or would you like it to, do you have a preference on whether it comes back to the board or not?
We can do both. So I can work with Danica and Isabel to get clarification on the language. I can send out a draft memorandum of agreement after it's gone through the provider organizations on the 28th. And I can either send it out for approval from the board, or we could make this motion and you give me the authority to work on an MOA, I guess an MOA, with the provider organizations and the healthcare authorities, and to make sure that it's meeting everybody's expectations. Up to the board. I'm happy to do either one. And then we can do an electronic vote since we're not meeting in July.
Would you need a motion for us to allow Carol to speak with HTA and not allow, but negotiate the contract with the providers, renegotiate the contract? Would we need a motion to allow Carol to renegotiate? And if it's only one line and on page 2, to renegotiate with the providers to have one MOA, and since you're going to be a part of that meeting, to allow her to go ahead and, if you feel comfortable, rewrite and approve and sign it.
I don't think we need a motion for that. I don't. The question is, do we want an approval of the MOA, or do we want to? Do we want an approval of the final MOA? So I think it's a question, or do we want to just authorize her to go forward with it? Does anybody have a preference, including Carol?
I think the memorandum of agreement is the right document. I think she should be able to go forward and execute that. Again, provided that it reflects collaboration between GCACH and the agreeing entity.
Anybody else?
I just have a question. We started this out as the incentive funding. Everybody came on board that are on board, and they were under a certain impression when they were doing the work towards that incentive funding. Are we changing the game? I mean, I'm sorry, but the connection, I've tried 3 times to try and get the connection better, but it's not working. So I'm just getting these little bits and pieces listening to this. But my assumption is that we already gave them information for the incentive funding. They agreed to that, and it feels like it doesn't feel comfortable to me going in and saying, hey, now, since you did all this, they already earned what you told them they were going to earn, and now it doesn't feel good. It's not setting well with me. And I'm just wondering, we approved for that to happen. Now we're going back and it's like taking your word back. This is what we were going to do. This is what you need to do. And now we're going to take it back. I don't like it. I just want to comment on that.
how is
It
this
doesn't
different?
feel good.
How is this different from anybody else earning an incentive?
Well, this is what I'm saying, is that I don't understand. We already had talked about what that incentive funding was. Am I correct? When people were coming on board.
Ronnie,
I might be missing something.
Yeah, I think you may have missed this part of the conversation. This is a separate pot of money specifically for the behavioral health.
But I think she's right.
Right.
We're talking what it took to earn this, and now we're adding conditions. So, and maybe I can be a little bit more helpful with what my objection is, representing my organization, is that this was a collaborative process, and we said, well, I'll be here and we'll go through this with you. The language as presented in this MOU makes it a hierarchical process where we, in effect, become a subcontractor to the ACH, and that is not the agreement. That's my objection.
So are you comfortable with, where we've landed for the moment? Okay. So, somebody on the phone?
Yeah, it's Caitlin. So I hear you, Ed, and I understand that totally. I think the problem is from a CMS standpoint, this is just the required process for the demonstration dollars. This is something CMS requires for 1115 money. It has to go through an intermediary, and for our state, it's the ACH. And then it comes down to you. And I think one of the reasons we need an MOU is there's a couple things the dollars can't pay for, which includes like paying for services that are already covered under Medicaid. And we may just need some provisions related to that in particular, or something, just some qualifying language, just so legally we're all protected in case there's an audit by CMS about the spending of these dollars.
So I'm not clear that these are incentive dollars rather than general fund dollars to achieve the objective of integrated managed care. These have been two separate projects that are now confounded by going through the same entity.
They're actually the same pot of money. They're all 1115 waiver dollars. And so the requirements are the same for all of those dollars. And it just, I think the way that it's been described has just been confusing, that it seems like general fund dollars, but it's not. It's waiver dollars. The 6032 supplemental budget dollars, that's different. But these particular integrated managed care incentive funding is just related to the waiver.
So if some of these funds were to come from intergovernmental transfers from other entities, how would they have been transformational dollars?
Intergovernmental transfers, and Kat's on the phone too, and she knows a whole lot about intergovernmental transfers and explains it much better than I do, but they're used as matching funds. For us, matching is not the right word, but basically, yes, used as matching funds for the federal government to be able to allocate a certain amount of money to the state. But it still all has the same qualifications as transformation or Medicaid, 1115 Medicaid waiver dollars. And that's probably why that might sound confusing. And we, I think that's some easy clarification that Isabel could do in an email about where these dollars are coming from.
So, and if that's true, then HCA misrepresented their position to 9 elected officials, indicating that this could be earned by simply submitting a letter committing to adopting 1 year early.
Well, let's get that clarified from HCA on the allowable uses, on what's required, on what's required of us, and then Carol could go forward with working with you all to find something that will be successful for the BHO providers. Okay. Moving on.
Is that going to be a motion?
I don't think we need a motion for you to move forward. We've approved the funding distribution plan.
Right.
So, and then I think when you get to a final MOA, then the suggestion was you were going to send that out, and potentially the board could approve that electronically.
All right.
Are we on the same page? Okay.
But with that MOA, though, are we going to get what are the responsibilities?
We're gonna get something in writing from the healthcare authority.
And then that's where I would want to know, so that when you read the MOA, is it consistent with what the expectations of the Because I would agree, we shouldn't overstep those bounds or impose additional things, but we do need to meet what is required.
I've never known a federal dollar to not have some kind of a tracking mechanism where there's some expectations.
Great, thank you. That's a really good discussion. Thank you, everybody. Okay, let's go on to the community health fund. We're just going to talk you through that.
Ruben, you want to come up here?
Yes.
Kids.
Or even over here.
Actually, in the city.
Or maybe even closer to the phone on this
Yeah.
side,
That's a good idea.
just because we're getting a lot of comments back.
We're going to be fighting for the same chair.
No, I would just kind of maybe closer to the phone because we're getting a lot of feedback that it's hard to hear from folks on the phone.
So I'll take this chair. I'll sit. All right. So why do I always follow a lively conversation? Okay, everyone. I'm going to talk about two things here. One is the community health fund distribution, and the second one is the methodology of to capture the consumer voice. So this is for the distribution of the community health fund. Last month, the board voted on the allocation methodology. So each region already has its amount allocated. So today we're going to talk about how we're going to distribute those funds. And like I mentioned, the Budget and Funds Flow Committee made a recommendation, and the board approved it last month. Soon after that, Board President Rhonda directed the GCACH staff to put together a distribution method that abides by a couple general principles. The first one being, as you can see there, that the funds must be administered by a third party, such as a philanthropic organization or a foundation. If a county does not have such an organization within their area, they can choose a nonprofit foundation of organization that does not have a vested interest in the funds. If they cannot find such organization, then the GCACH can choose to administer the funds ourselves. Second principle is that the land develops a framework for searching and selecting that third-party organization. They also develop a framework to capture consumer engagement.
The microphone and then I think projector.
Yes. Turn off your microphone. Oh, okay. Oh, airplane. I like it. I saw you looking at me like I was God. But I really didn't hear it. I was the one talking. Okay. I'm like, all right. So where was I? Okay. So the framework, the lens put together the framework to capture consumer voice and consumer engagement. The lens involve the consumers in identifying the priorities, specific social determinants of health there at the local level. They can use the local assessments, community health plans, or the Robert Wood Johnson Foundation health rankings may be used for those purposes, so they can find all the sources to identify those social determinants that they want to address.
The third party issues the request for proposal to select the projects, while the GCACH provides a request for proposal for the LINs to use a template, and then they can modify it to suit their needs. The third party evaluates the bid and selects the winners. The third party awards the projects. The third party manages and evaluates projects, milestones, and deliverables. So that's the distribution of funds right there. The other topic that we discussed is capturing the voice of the consumer. Okay? On June 4th, the GCACH convened the first quarterly meeting of LIN representatives. And as you can see the list there, these are the names of the people that were part of that group and the LINs they represent. So after a few minutes in the conversation, it was very clear to us that the Consumer Council model that most other ACHs are using was not going to work for our ACH. For one, other ACHs only had one Consumer Council, whether they were in one county or whether they were in 7 counties. They only had one Consumer Council organized with the chairs and co-chairs, and they had a lot of ACH staff assistants. They had a coordinator who actually ran the meetings until the co-chairs and the chair and co-chairs were selected. But still, those Consumer Councils depended a lot on the ACH staff, and we discovered that model wouldn't work for us, because then we would have like 8 Consumer Councils, because Columbia County, Barfield, and Asotin, each of them would have their own Consumer Council. So that would mean a significant cost to them to administer, to dedicate maybe a staff member to coordinate the Consumer Council meetings, and also most of Consumer Councils pay a stipend, so that would signify some additional administrative costs to each Consumer Council. So what we decided to do, based on the feedback with all of these LIN representatives, was to pretty much scrap that and do our own, to allow and this bottom half of this second page, you'll see that Jack Davis, Kurt Williamson, Rhonda, myself, and Carol, we created a subgroup there, and so we look into what alternatives we can think of that would fit our region better, because of like I said, the vastness of our geography and the very sparsely populated regions within our ACH. So here's what we came up with. The first bullet point there is to allow the local health improvement networks to develop their own framework on how they're going to capture the consumer's voice. Because only local leaders that know the challenge they face, the challenge they have to overcome, they could form the Consumer Council the way we originally intended, if they choose to, or they can tap on existing consumer groups that are within the CBOs or within the MCOs. School districts have parent groups as well, and many other organizations. Tierra Vida, they have a community there. They're organized, so we can reach out to such groups. And so the Yakima County Healthcare Coalition, in the last meeting, they Sandra, you're one of 2 people working on this. They're working on the framework for how Yakima is going to capture this consumer voice, and hopefully, we'll distribute it to the rest of the LINs, and hopefully it's a framework that fits everybody. If not, I'm sure they can modify it to get their needs.
I can tell you this much: the framework matches what will be required for reporting by the ACH. Thanks, Carol.
So it was also agreed that that the consumer voice is going to focus mainly on the social determinants of health. Certainly, we're going to seek to also capture information that will help, that will yield information on how to address the 4 projects, but it's going to be through that lens of the social determinants of health.
Can I ask a question?
Yeah.
I'm a little getting lost. When we're using the term consumer for the scope of this project, how are we defining that? And the reason is that so I sat through part of Walla Walla County's process, consumer engagement process, and they identified a lot of, I thought, were really good prevention opportunities that, if properly executed, you wouldn't see people, penetrate into some of the healthcare concerns or even behavioral health concerns. And so, are we widening? Is there a wider definition of the word consumer, or are we really looking at feedback from that group that ends up in a healthcare setting or physical behavior?
The healthcare authorities is very descriptive that we must have Medicaid consumer input. So they have to be Medicaid beneficiaries.
But not.
Several.
No, that's what we know. So, I mean, your question as always, are they a recipient of healthcare related services on top of being a Medicaid beneficiary that you're asking?
Yeah. I mean, would they have to be in the project groups, or are they just representative at large from the community who are living in poverty and have Medicaid as a health care?
Primarily, that focus is on social determinants, so it would be Medicaid beneficiaries.
Okay, right. So the big partner for us here is probably the school districts, right? Because they have a lot of the Medicaid covered kids.
And that's the conversation that we've had at the county, our county health coalition, is that we have a very different definition of consumer engagement. And I understand there's research presented tomorrow morning in our coalition, but our definition is going out to where the people are, not having them come to us.
Our definition doesn't exclude the school district.
Yeah.
But they're definitely not your major player either. So it just involves really more grassroots outreach and involvement of organizations who are doing that work.
But I think what Ed was saying is the school districts are nice because they're it's a captive audience there. Like,
yes and no.
It's a common denominator.
Yeah. Yes and no. I think there are certain elements of targeting schools that makes it easier. They do have parent nights and things that you could get involved in. They also have social workers throughout the school district that target certain populations. So it wouldn't exclude them, but at the same time, we also recognize that adding one more thing to a school district list of things to do, in addition to educating our children, might also be a very big ask when there are other groups who might be better positioned to help us, and other things that partners within the local health improvement network are doing that could be enhanced or expanded to meet the needs.
Well, I think that'll look different throughout because I think it'll look really different throughout the region. And so here in Walla Walla, I mean, our public schools are more than happy to collaborate. And so.
Yes, and that's the main reason why we decided to go this way, to allow the local lands to develop their own framework. And they pretty much define who their major partners are going to be. Right. Okay, so the third bullet point there on the second page, so the GCACH will provide the lens with the survey questions to capture a standardized voice throughout the region, with also with the flexibility for the lens to ask more localized questions for their own purposes.
A question.
Yeah.
What's the process for developing those survey questions, or how do we measure its relevancy to the consumer? And
me sitting on my desk. No.
Yeah, we have that same question in Nassau County.
Well, no, I'm putting together a list of questions and they're probably going to differ as we grow. They're probably going to differ depending on what we're trying to capture. Right now, I'm putting together a list of questions that then I'm going to, take to the process of, is this relevant? Talk to Sam, talk to Wes. Does this capture the information that we need for us to implement what we want to do? And so that's pretty much the process here. And I don't know if it's necessary to bring them to the board. If that's necessary, we'll bring them to the board as well.
So what are we going to do with this information?
We'll capture information to follow their direction on how to address what social determinants of health to address, and also to collect information for the different projects.
But didn't we already do social determinants of health by county?
Yes, but they will decide which ones
Not at the
to
consumer level.
Oh, so they'll, among the for Benton County, they'll decide like a
to
priority.
prioritize what they're going to address.
Okay. Yeah.
I might recommend that you maybe find an ad hoc subgroup to help with the writing of those questions. That's a lot of, that's a heavy lift for just one person.
It is, but I want to go to them with some.
Established social determinants.
Yeah.
That you might use. There's, HHS has one, a lot.
Kind of why I was saying maybe an ad hoc group to help, because a lot of us know those tools and could maybe come with those to help guide those questions versus.
There's some tested tools that are available for social determinants, and that might be better because they've been tested already.
What's the organization you mentioned?
Well, yeah, we
had
a couple of months ago, we did at our coalition, we shared, our workers shared theirs, we used the Prepare tool, and then.
We have a modified Prepare.
What's her name? Deb Gout shared the one from, was it CDC or HHS? No, I can't
remember.
But there are a few screening tools that are pretty consumer friendly that are out there. So you don't really have to recreate the wheel. And might suit our needs just fine.
I was kind of why I was recommending maybe an ad hoc group, or even if you just convene the leaders of the lands to be like, what have you had from? Because you could go back to the minutes and these are the things that were shared when we did that.
The ones that we should use at the coalition, because I think I have.
Yeah. Because otherwise it's really heavy lift.
I don't have the tool that Angelina did. She just shared the results.
We can do that. Yeah.
Yeah, I'm pretty sure you're very aware of the translation, not just in language, but also the cultural translation.
Interpretation.
People interpret our questions maybe very different than what we're asking them. So I think that's probably the biggest task in my mind.
So going back to the point is that, yes, we would have some standardized questions to capture whatever, project that, they might want to hear from the consumers. Then we'll devise or write some questions. And I don't know if there are any questions already out there written for everything that we're going to want to find out, but that is the point of this bullet point, is that we're going to have some standardized questions and allow the local health improvement networks ask some of their own more localized questions as well.
In the West, very kindly handed me, so this is from the semi-annual report, the questions that are being asked at the ACHs, which is community engagement. Community engagement refers to outreach to and collaboration with organizations or individuals, including Medicaid beneficiaries, which are not formally participating in project activities and are not receiving direct district funding, but are important to the success of the ACH project. So it asks us to list all of the different activities that we have had with, in terms of community engagement. And then there's another question, describe how the ACH and its partnering providers have reached out to populations with limited proficiency in English, and then focusing on community groups that may be underrepresented in transformation efforts, identify challenges to engagement that occur. Describe the strategies ACH and its partnering providers have taken to address those challenges. So there's an expectation of community and consumer engagement.
Yeah, and I just want to kind of put out there too the importance of getting the information involvement, because you guys will get a lot of data that we have that you guys don't access. Because we have I mean, it's in the paper, we have a high suicide rate right now, and it's increasing. And our program is strictly Medicaid, we're not tribally funded. So we have a hard time getting a med provider. I mean, so those are just, technology, Carol knows, we're doing everything handwritten. We don't have an EHR. And so I think it's really important that when you guys are all talking about all these millions of dollars, and I'm sitting here really concerned about how much you guys are taking into consideration our tribe, and we are over 11,000. That's just enrolled Yakima. Our clinic serves all enrolled members or descendants of. So we are way over 20,000 that we provide services for. And so, I mean, you guys are talking about really big money here, and the tribe is, we're functioning on what we have. So like, when you guys do these surveys and you guys are asking for these questions, please come to us. Let us help you get some of that data so we're represented. I mean, I think that's really important. When I take this back to Lottie Sam, who is our chairwoman, she asks me these questions. And I'm sitting here just in awe, like, wow, that's a lot of money. And we're serving how many people? And we don't have any of it.
So kind of just remember that we have a set aside for the Yakima tribe. So the lands are getting a certain amount, the Yakima tribe has been allocated a lot more than that. So we're still working through I'm interested in the data. I mean, we need to be a part of that data. And we've asked several times, we're hoping that someday we'll be able to get permission, but right now there's a lot of.
Well, we've had 2 of our tribal councilmen pass away. So we just did yesterday elections again. So, I mean, this is going to be an ongoing effort. And like I said, I'm going to be available and pushing conferences, whatever meetings you guys need. That's what I'm here for. And so whatever I can do, I want to be a part of that and try to get that with our tribe.
Thank you very, very much for that response. It really helps you and it helps us get through this.
Yeah, it really does. You've been a great help.
You have.
Well, I just want to continue because I'm here as one of the over 11,000 Yakimas.
And we are continuing to reach out, and we were just there on Monday, and we're going to be there tomorrow also to meet with some providers. And we are treating the Yakima Nation as what it is, a sovereign entity. And,
right, and that's the hard part too, is our legal part. It takes us such a long process because, like, if you guys want something by 28, we're never going to get that done if you just bring it to me today. It takes like months. I'm sorry. But with the turnaround with tribal leadership, and then we have to go through our tribal attorneys to protect our sovereignty rights, there's a lot of issues that go into that. And so kind of be aware of that and just be open with that too. It may take us a while. Like, we didn't get in on the first LOI because it stopped at our tribal attorneys because they have to go through all of it to make sure our sovereignty is safe. So just kind of be aware of that. And I'm not complaining. I'm just sitting here listening and just kind of letting you guys know what I have to do when I go to Lottie.
Thank you. And please go.
Not just a therapist. I'm a therapist by trade, trying to keep up.
Yes.
Move you along.
Okay.
We've got a few more
Yeah.
things on the agenda.
So these have been some of my concerns because there's a variation of demographics that we're looking at across the board. School districts are fine, and wow, we've got youth there, and there's many of them. I did some research a few years ago when I was doing an event with Spokane Parks Foundation, and part of that was what the demographic of the youth look like in public schools. But then you have the tribes, then you have elderly, then you have homeless. So the variation of demographic is there in each individual community that we're serving across our region. And I think that it's very important that we don't silo ourselves to one over another. We have to look at the whole body, because if we're not looking at the whole body, we're not fulfilling the needs. We might get more on one side than the other. And I just think that the distribution is so important when we're talking about consumers. And I think that trying to reach out and meet those needs, sending it to the LHINs in those areas is one thing, but being sure that we're touching the variation of those demographics, I think is most important. And so that's my 2 cents, whatever that's worth at this point.
Yes, yes, Ronnie, it's worth a lot, and that's the next bullet point on the next page. But before I move forward, Tanya, please continue to give us that guidance. Okay, we do our best, but you know, maybe not all the time we're going to be doing our best, and we appreciate your guidance.
Well, even my best sometimes isn't enough. But I'll do what I can.
Yes. So on the next page, the last bullet point addresses what Ronnie just mentioned. So the GCACH will provide the guidelines for the number of consumers to be surveyed and give indications as far as the gender, age, race, English proficiency, and ethnicity breakdowns requirements for those surveyed to ensure the voice reflects the demographics of the region. Okay. The last page. These are the non-allowable expenditures, which pretty much mirror what the LHINs have on the contract, the federal guidelines. I added more detail on those unfilled bullet points. I added more detail to allow the LHINs to lease equipment because they cannot purchase equipment, but to allow them to lease equipment to make sure that goods and services reach those that is social determinants that we're trying to address and reach those consumers that we're trying to help. Same thing with the cost of ordinary normal rearrangements. In some states, one of the major social determinants that they're addressing is making modifications to people's homes so that the elderly don't fall and break their hips. So they use some of this money to install guardrails. An asthmatic person, they use some of the money to install air conditioning. So I reworded or added some clarifying language to allow those kinds of expenditures. Okay, so that's it pretty much. So the changes we made on the distribution list is to ensure that we avoid conflict of interest or the appearance of a conflict of interest, and also to allow the local LHINs more flexibility, more freedom, so that they can address their region-specific social determinants of health. So,
can I ask you something, Ruben? What's the oversight of the LHINs? Because I understand that they're in their region and they're working towards the same goals, but the inclusivity is super important here when we're talking about consumer voice. And guiding that consumer voice, I don't know how to put this into terms. Hang on a second, let me get my thought together. The importance of is the end user and the struggle that they have. Typically what I found as a consumer trying to work with agencies and organizations and those that are in positions of power over my need, I find that I don't get the outcomes that are necessary. And doing outreach and being in the community, working with consumers, whenever there's something that, I guess I'm talking about the fidelity of the LHINs. What's going to manage that fidelity? So that the consumer voice and the consumer need is being met across the board and not silenced because there's a non-agreement with, oh, well, that's not important enough kind of idea. I don't know how to put it in words, but I know that it gets frustrating at the end user place when you go in and you're trying to get services and the criteria, it puts you out by a hair, and it's like, where do I go now? Who do I see now? So I'm just thinking about the consumer and how it'll play out for them. I mean, we know that the majority rules, but there's also spaces that start lacking, and people's lives are touched significantly because they didn't meet the full-on criteria for one thing over another. So the consumer voice to me is very, very important to listen to through this and reaching out
Ronnie,
to.
this is Rhonda, and I would agree with you. I think that, each LIN has to make sure that they have, that they're picking. That's why, it's one of the reasons I think in our conversations why we really wanted this to happen at the local level. Because we all want to be effective in incorporating the consumer voice into our plan. And so, each LIN has an agreement with the ACH on how they're going to include consumer voice and how. And some of us felt it was more effective, at least in ours, that doing outreach and going out into the community is more effective than asking people to come to a table a couple times a year. So
I agree with that.
That in your community, I mean, that will be an important that you're in part of that, and you can make sure that you can feel comfortable with that. I know that we'll be doing that in ours, and I think that the people that are involved in each of the LINs, I mean, I think we have solid representation that the LINs are going to be committed to doing that.
Yes, and there is an expectation that the voice reflects the demographics of the regions.
So I'm going to ask that we can move on. We're almost out of time, and we still have a couple of other things to go through. And, we can also have this conversation online if you want to talk about it more in depth. I'd be happy to talk to you, and I'm sure Ruben would as well. So let's go ahead and let's zip through. We can talk about the letter to Senator Murray. Oh, yeah.
Proposed recommendation.
Oh, yeah. So I would love to entertain a motion to approve the distribution of capturing consumer voice. Moved by Carrie. Is there a second?
Second.
Second by Ruben. Is there any other discussion? All in favor?
Aye.
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 Any opposed? Any abstentions? Okay, thank you. Thank you. So now, letter to Senator Murray.
Okay, so the letter to Senator Murray is in your packet. It's really regarding the use of people that have gone through mental health training that are highly qualified, that are denied for various reasons to work to their license in specific areas. Honestly, Ed probably knows more about this than I do. This is a letter that I copied from the Bent Franklin Community Helpline, who had this very similar letter that went in front of their leadership council. It's really just bringing to the attention to our congressional delegation that there is a shortage of mental health providers in our area, and that there is an amendment of the Social Security Act to cover marriage and family services and mental health counselors, and expand access to services, especially in rural, underserved communities. So this would just be a letter to our senators asking them to support this legislation at the federal level. That's the bulk of it.
Is that the one aimed at expanding the pool of staff from Medicare eligible?
Yes.
Okay.
Yeah.
Medicaid already. Any questions? Okay, so I have a motion to support sending this letter.
A motion.
I second.
Second by Ronnie. Any further discussion? All in favor?
Aye.
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 want to
Hi.
start? Caitlin, you were in support, right?
Yes.
Okay, thank you. Any abstentions? Thank you. Approved. Okay, preliminary results of the CSA.
Okay, real quickly, 110 question CSA was created with the help of CSA being produced by other agencies. It went through a lot of iterative changes. OHSU helped us develop the survey. It was submitted on May 9th. We went up to 78 organizations who responded to the letter of interest in 2017. Out of that 78 organizations, 55 responded back within the...
Wes, can you speak up?
So 55 responded back within the timeline that was proposed. Which was a response rate, we're all blaming Ruben for that. Which was a response rate of 70%.
Yeah, get that clarification in there.
The record show.
Standing ovation for Ruben.
There we go. So we had in the response broad representation across the sectors, broad coverage across the project areas, and broad coverage across the counties. I won't go into the detail of the 3-page document, but let's just say this is the preliminary analysis, and certainly more will come because it's a major part of the semi-annual report. Any questions?
Go on.
That's it. Sure.
So in part of that dialogue, unless it's what we're moving to next, there was what OSHU saw as high value for high priority partners, and then local ACH. And we talked about the idea of asking them to give us the scored results. And were they willing to do that, or will? Okay, good.
We've asked them to. We haven't received a specific response back. Okay. Yeah, we have a general description, but we're looking for more clarity in how they score each of the individual organizations.
And they said they'd be willing to do that. They just want to get clarification on what kind of comments do we want them to give back to us. And I would just say any reasons why they think that they should have been scored in that higher tier.
I think what we really want to know is help us discern what it was that we either didn't describe that we do very well, or what we really don't do well. And I'm not sure that's what we're hoping for.
To be honest, that there may be a write back process that we do with organizations similar to what the GCACH went through when we did our project plan proposal in November of last year. So if we see that there's some holes or some questions that weren't fully responded to, we're considering whether to send those back to the organization and ask them to provide some further support. Because they commented outright that they saw some good applications that simply didn't have comprehensive responses to the back.
Thank you.
So we're going to talk about the prioritization.
Yes, we are. So
3 minutes.
I will direct everybody to this table that says CSA tiering analysis. And we are not, I would say we're not finished with this, we're just starting down the road, but we did ask OHSU to go through all of the CSAs, and they did so with the help of their a physician with OSH, GCACH personnel that looked at these that were experienced in practice transportation. And they listed, in their opinion, those practices in the high priority that could that were primed to capitalize on GCACH, which is support and make meaningful progress toward transformation. I think the question that was asked during the practice transformation work group meeting was, did they use that tiered to the scoring that that the practice transformation came up with in terms of the 8 change concept? So the answer was not necessarily. They were looking at the applications as a whole to say, do they have population health management tools available? Do they have the kind of EHRs that are set up so that they can start implementing and measuring progress? Do they have the type of leadership that's being amenable to the principles of practice transformation, either team-based care, or they have some of these models in place that they that was really the extent of their evaluation. However, Sam also went through the same CSAs, and given our knowledge of the system, and which we have a little bit more knowledge than OHSC did, because honestly, when you looked at some of the CSAs, they weren't even filled out 50%. So it was difficult for them to judge an organization based on 50% of the information. Some of them just simply didn't answer some of the questions. So it was difficult for them to say, well, this is a great organization, or they're fine, when they didn't have all of the answers. So I think that the next thing is that staff has to go through again, take a look at the geography, take a look at, for example, there's nothing right now in Whitman County. There's not any of these organizations that have been listed in the high priority that are from Whitman County, and our goal and our endeavor is to try to have at least something in every county. So this is just the initial breakout of these organizations and how they work. I don't know, Sam, if you want to add any additional information.
If you do, go by the phone.
Do we need to add anything at this time? I think that we break up. Right. The only thing I can add is whenever we were looking at the different project areas.
Nobody can hear you.
I don't think it works. So is it broken? Yeah.
So it's a battery.
Ruben broke it.
How about us, Phil?
The one thing I can add when we're looking at the project areas is focus more on items of the families that we have approved, or the board for like leadership, working project studies, those sorts of things. And a lot of these entities that are high, there's so many more that are high, needed less support, or they were going to do model clinics, and they were going to support the transition for other entities by education. But I think that that's the variation in more of the high volume for the GCACH as opposed to OHSC.
And do you want to explain this?
So, yeah, I'll let Wes explain.
So this is a grid that was put together with the organizations that are colored green on this table. The ones that are green here and green here have dark orange highlight. That's in the second column from the left. We also indicated the counties that they marked off in the CSA that they were currently operating in. And the third column over, the fourth column over, represents the project areas, 4 project areas that they were interested in collaborating in. And then there's a question, number 74, for them to identify the top organizations to which they refer or transfer most often. So what we did is, it helps to have another document, which we don't have here, that came from Chris Kelleher at OHSU, but he was trying to create a framework that saw the relationship between what are called track 1, which are labeled as practices, and track 2, which are labeled as partners, to show the relationships between practices and partners. Think of it between that sort of clinical community relationship in some respects. So, for example, the second row, Yakima Ashland Regional Medical Center, their number 2 is comprehensive mental health, which is highlighted in green. And if you go down to Mastery-Toppenish, comprehensive is also highlighted in green under response number 5. Then you'll see some other areas where comprehensive is highlighted in green. So for certain organizations that were outside the system of that particular health provider, we were looking for commonalities. So you can see where comprehensive stood out. You can see where H&M long-term stood out. You can see where adult protective and child protective services stood out. Sundown Ranch, as well as Triumph Treatment, stood out. So we were looking for those organizations. We were looking for those organizations where there was some commonality in terms of referrals going up. We wanted to ensure that all the right organizations were included in our network.
I'm sorry, can you remind us again what the colors, what's significant about the different colors?
It just means that they appeared more than once. And those are not the only organizations that appeared more than one time. I didn't do this for FQHCs. I didn't do it for specific provider organizations. I focused on behavioral health and other social service organizations.
And what's the 1 to 10?
That was how many opportunities that they had to write down the pearls.
Can I ask on, it says, please identify all the counties where the majority of the patients. That was within that organization, right? So if you're only in Garfield County, it'd be Garfield, but if you had all 8 counties, it would be where you have the most votes, right?
Right, and when we say majority, we didn't qualify that with a specific quantitative criteria. It was sort of left open. But I mean, if you have 5,000 people in Yakima and only 2 people at Franklin, then we would assume you would check that. Questions about that? Just a framework to help us understand where patients, clients are going for services, make sure we represent that too.
Okay. So our next step with this report.
So the next step is that we are putting together more information to the practice transformation work group next Thursday with the recommendation of approving a final selection of the first tier of organizations that will do practice transformation under the contract. And then that will have to come before the board.
And at this point, are we thinking the board will meet in July or will not?
Well, if the board wants to meet in July, that would expedite being able to start writing the contract.
What's your recommendation?
Recommendation is going to be let the staff figure out how much more work needs to be done in order to put together the priority list. There's more information out there that we really need to analyze in terms of demographics and so today's meeting, the district council meeting, was really to confirm the target population. So now we have to go back, take a look, and analyze some of that data to make sure that all of those target populations and project areas are being covered.
So realistically, with the semi-annual report and the amount of data, the quantity of data, it's probably best if it's August versus trying to rush something that maybe isn't as comprehensive as it could have been.
I would say no later than August because you really need to get going, but it would be a great review to have until August to put our recommendations together.
So we have the implementation plan that's due at the end of September, and all there's no dollars tied to it. We consider it, we want our stakeholders and partners to consider it to be very important piece, and we want to try to get some of the stuff resolved before that gets ready.
So the first tier consists of like X amount of
I'm having a real hard time hearing anything that's going on. It's very muffled, and it's very just in and out.
And I would agree with that.
Plan on having our next board meeting in August, where we will be revisiting these documents and hopefully a recommendation from the practice transformation work group on the first tier, which is on which list you're going to look at for the first tier, or something different. Okay. Okay, so the last item we have is the car leases for the staff.
Kylie might not be on the phone.
I'm still here.
Okay, Kylie, take it away.
Yeah. So basically, we did a cost analysis. Obviously, per our employee handbook, we've been reimbursing any staff that utilize their own personal car to drive anywhere for work at the IRS rate, which is the 0.545 cents per mile. So we did the cost analysis on what it would cost to lease a car as opposed to what we're paying out now, and it was significantly less and a lot of savings, almost double the savings actually, to lease a car. However, when we went to, we tried a few companies, they basically said, you know, we haven't been around long enough and established enough credit. So in order to lease, we would have to have a personal cosigner. So obviously, you know, I don't think anyone really feels that comfortable doing that. So we were kind of looking for if anyone at the table had any ideas or information that maybe we could go through the process or attempt to lease a car.
Sorry, but I just went through this with one of my kids. I can't do it. I have to outright purchase and then just when the mission's concluded.
An allowable expense.
I think that's a good idea.
It's not allowable expense if you didn't hear on the phone.
So even with a large enough down on the lease, they
We can offer to pay the whole fee up front. And if they still.
I mean, did you talk to more than one place? That's great.
Yeah.
I know, we're like,
Yeah,
awesome, ready.
We've worked with we tried Ford, Hyundai, and there's a second Hyundai in Yakima that I'm trying to work with now also, and Toyota. So the consensus is basically that we're too brand new, and because we're nonprofit, no bank wants to really lease to us.
Did you show them the amounts of money that's in the bank?
Yeah. Yeah, actually, it's really interesting because we tried multiple avenues, and, you know, I provided financial statements, and we tried to say, you know, we'll pay all up front. We can even put a retainer on there if you guys are worried about that. And it was just across the board, no.
Did you talk to McCurley?
yeah, I can you give me a day and I'll call you tomorrow.
Great, thank you, Ed.
Yeah.
You just said
Yeah.
you could do it.
I'm not going to co-sign. but I know an owner who would.
You don't, I know a couple of car deals might be able to make a couple
Right.
calls. Well, I bought enough cars from them.
They always.
Okay, all right, so we are a few minutes past. Is there any other business for the good of the order? If not, can I have a motion to adjourn?
So moved.
I motion to adjourn.
Great. Thank you. See you
Thanks
on-
everybody for being there.